Hello everyone, I'm back with some more guides and today we're going to talk about the urinary session. We're going to talk about all the urinary diseases with the patho, the function, the phases, the labs, the assessment, all of it. So let's start with the acute kidney injury, AKI. Basically, it's a rapid loss of kidney function, but it is reversible, right? Because it's acute. Um, The goal is to know what caused the AKA and to prevent the chronic kidney disease. Okay. Causes it could be pre-renal failure, intra-renal failure, and post-renal failure. Pre-renal failure is basically like a low BP or low heart rate, and the blood is not getting into the kidney. Intrarenal failure is like basically damage inside the kidney, and post-renal failure is urine cannot get out of the kidney. Okay, there's three phases. The most important phase is the oliguric phase, which is basically reduction urine output, which is less than 400 ml per 24 hours, or 30 ml per hour. The GFR is going to be less than 80. You have the diuretic phase, which is basically there's an excessive urine output. It's a good sign. That's how you know that the kidney is gaining its function back, and it's improving. Recovery phase is basically the urine out is normal and the GFR is normal. So labs, how can you detect that the kidney is not working? You're gonna check the GFR. If it's 80 and less, it's AKI. You're gonna check the BUN and the creatinine, and they're gonna be elevated. Assessment for the oliguric phase is gonna be edema, AMS, elevated BP. Lungs are gonna sound like crackles, Kussmaul respirations, and pericarditis. There's a friction rub. Labs, you're gonna check sodium, potassium, phosphorus, BUN, creatinine, and all these again. Um, Priority assessment in diuretic phase. So now we're moving on to the diuretic first, but before we do that, make sure you wanna watch for metabolic acidosis with oliguric phase, okay? So priority assessment in diuretic phase. So you want to think opposite of the oliguric phase, right? So they're gonna have to put it both right next to each other so you can see them. Um, is think opposite. So low BP, low HR, dehydration. You want to listen to the lungs and the heart and improvementation. The labs for the diuretic phase is going to be the opposite as well. Sodium is going to be high, potassium is going to be low, phosphorus is going to be low. And it goes on and on. And here you can take a screenshot of this screen and you can compare them both together. Um, there is a contraindication in PT with AKI because it's the CT with the patient with AKI, CT with contrast, and IV fluids. These are contraindications. Priority intervention is going to be strict IZ nose, daily weight, fluid restriction, and neuro checks, right? Q4 neuro checks. Treatment, you're going to do a continuous renal replacement. Therapy is usually performed in the ICU. And it basically takes over the kidney job. And then medication, you're going to use Lasix because remember, you're not urinating out, so Lasix is going to help urinate. And then mannitol, it's an osmotic diuretic. Medications, you're going to take K-exolate, slow acting. Why would you take K-exolate? Is because when you're giving you Lasix, you're using a lot of fluids. K-exolate, when your potassium starts dropping, will switch Lasix with K-exolate. K-exolate is the same as Lasix, however, it keeps the potassium and does not touch the potassium. You're gonna take calcium gluconate, dextrose, insulin. These are how to correcting the potassium. Complications, you're gonna have CKD, hyperkalemia, central line infection, or folio, or whatever you have. That's that's okay. It's not that important or related to urinary diseases. Patient education, of course, you want to tell them about what's going on, what do they have, the diet they're supposed to be, like low protein, low sodium, high carb, the medication adherence, the education about all the meds that they're getting and how important they are, and to monitor eyes and nose as well. Um, Chronic kidney disease. Chronic kidney disease, basically, it's a progressive, irreversible loss of kidney function. We can't fix it. Priority assessment is going to be edema, elevated BP and HR, and crackles in the lungs. Priority intervention is going to be strict eyes and nose, daily weights, fluid restrictions, infection prevention. These are going to be for the same AKI and CKD. The labs you're going to do the BUN, creatinine, the GFR usually starts less than 15. The AKI is less than 80. This one is less than 15. You're going to check the urine specific gravity, potassium, phosphorus, and all of these labs. As far as medications, you're going to give K-Exolate to keep the potassium, calcium gluconate for the potassium, silvermere phosphorus binder, calcium acetate, Ringo, and Epigen and Epoetin or iron sulfate. It just depends on the patient. Treatment. So we have hemodialysis. Basically, it administered 3 to 4 times a week for 3 to 4 hours. Okay. So, your patient is at risk for blood clots from sitting in the chair for several hours. So heparin is really recommended. And you want to assess for the AV fistula, the AV graft. You're going to palpate the thrill and you're going to auscultate the bruit. Okay, remember those. You're going to palpate the thrill and auscultate the bruit. And if they have a CVC, you want to make sure your main concern is infection. Nursing interventions, wait before and after. You're going to do the labs before, vitals, assess the patient, and education, education, education. Peritoneal dialysis is basically more convenient. There's 3 phases: fill, dwell, drain. Nursing interventions, warm solutions, strict eyes and nose, wait before and after BP, lung and heart sounds, like just a regular assessment. You want to assess the catheter site for infection. Make sure the catheter is not kinked, or if the patient is experiencing any pain or severe pain in that area, make sure you report it. Complications, it could be constipation, short of breath, crackles, or risk for peritonitis. Kidney transplantation. So, old kidney is never removed. Okay? I know that might sound funny if you've never heard that before, but the old kidney is never removed. Post transplant, basically, you're gonna do a urine output monitoring, strict eyes and nose, and daily weights. Sometimes, if the transplant is given, they may still get dialysis to jumpstart the kidney, but most of the time they don't. Immune suppressants for the rest of the life and infection prevention to prevent any rejection of the kidney. Um, Urinary tract calculi basically is just a kidney stone. It's caused by like dehydration, drinking enough water, diet with high calcium, high vitamin D, and uric acid. You're gonna assess the pain. You're gonna have a flank pain, nausea, vomiting, WBTs in the urine. Anytime the patient presents with a kidney stones, always collect the urine to get tested for everything. You want to do the pain management, like you give them strong pain meds, increase fluids, IV fluids, and strain the urine. Complication, AKI or infection. The diet is going to increase fluid 2 liters a day, low sodium, vitamin A, vitamin D, and low calcium. And the treatment, oh, that was the treatment. All of these that I told you about, the diet, the fluids, and crush a stone, monitor for stones to pass through the urine so you can see them. Urinary tract surgery, you have a urinary diversion, urostomy, Basically, it just connects both one ureter and the stoma so the urine can exert it through the urostomy bag. You have nephrostomy where percutaneous tube is inserted into the kidney and the urine is drained out into the nephrostomy bag. You have the three-way bladder irrigation. Is basically there's a video, I will post the link. Um, but you want to remember with irrigation, what you put in must come out. Okay, if the patient reports any cramping, pain, stop and slow down and slow the rate of the irrigation. That was a question actually in my NCLEX exam. Infection prevention, monitor the patient abdomen for signs of infection. Post-op and pre-op management care, of course, like strict eyes and nose, the daily weight, infection prevention interventions, and deep breathing, IS. Check the tubing for output, increase the flows with the patient, and monitor the back drainage. So, since we are done with the urinary diseases, I am going to go ahead and tell you some from my papers, okay, on what to expect in your exam or what's really important to focus on. So you want to always remember the phase of the AKI that is all uric phase, okay? You need to remember this, okay? I'm going to remember all the specifics when I said less than 80, it would take 1 to 14 days. If they're going to be less than 100, less than 400 ml per day. Priority medication, remember all that. Remember K-exolate to keep the potassium. Oh, remember the daily weight. Remember, you need to make sure you have the daily weight before and after. Every day, every day. For chronic kidney disease, same thing. Remember the labs that you are gonna check. Remember, remember the priority nursing implications. What would you do? What would you not do? The medications, and remember, all of them are gonna be on strict isomers. Okay. Remember when it comes to the peritoneal dialysis, the fill, dwell, and drain. Okay, fill is inflow. Dwell is when the time of the dwelling, and then drain is the outflow. Okay, remember that as well. So you want to remember as well. You want to avoid salt substitutes because it contains a lot of potassium and high potassium. You want to use sterile techniques when it comes to like Foley and like CVCs or like any um, anything that the patient has, lines. You want to make sure you do a sterile technique to prevent any infection, and of course you want to report to the healthcare provider all of like after the peritoneal dialysis, what was the weight before, what was the weight after, if there's a cloudy outflow that was not there in the beginning, low-grade fever, tachycardia, or any severe pain that the patient might experience or complain of. Make sure you listen to your patients and make sure you actually interact with your patient, because most of the people that go to dialysis, they're not depressed, but they have to go there like 3 days, and that sucks per week. So make sure you interact with your patients, ask them what's their favorite stuff to do. And you never know, you might find out something new that the patient has as a new symptom, but the patient does not know that it's a symptom. So good luck and hit me up for any questions in the comments. Thank you.